Hello, and welcome to this Pro CE podcast. I'm your host, Kim Neely. Today's episode features a discussion on the burden of and screening for undiagnosed nonvalvular atrial fibrillation. This episode is part of a larger educational program titled An Untapped Resource, Pharmacists' Role in Improving Screening and Management of NVAF. During this podcast, Dr. Kathleen Lusk from the University of the Incarnate Feik School of Pharmacy will provide an overview of the prevalence, burden, and consequences of NVAF. Dr. Stephanie Dwyer Kaluzna from the University of Illinois Hospital and Health Science System will review guideline recommendations for NVAF screening and pharmacists' role in screening in various settings. For more information on Dr. Lusk and Dr. Dwyer Kaluzna, along with CE-certified micro-learning modules with downloadable slide sets, a clinical thought commentary, and a downloadable infographic reference guide, please visit the show notes for this episode. Now let's get started to hear about this important topic.
Thank you very much for that introduction and all of that helpful information. So let's dive right in and begin with our discussion on the incidence and prevalence of nonvalvular atrial fibrillation, as well as the burden that this disease state has on our society. The learning objective that we will partake in over the next 15 minutes or so is we want to recognize the prevalence, burden, and potential consequences of undiagnosed nonvalvular atrial fibrillation, including an assessment of a patient with increased risk factors. So beginning with the incidence of atrial fibrillation, this is the most commonly diagnosed sustained arrhythmia here in the United States, and the incidence is on the rise. We can see that back in 2010, about 5 million patients had the diagnosis of atrial fibrillation, and this is expected to over double by the year 2030, with 12 million patients earning this diagnosis. Moving from total diagnosis to new diagnoses or new cases, we see that this has also over doubled from 2010 to where we expect it to be in 2030. With in 2010 having just over 1 million people earning this diagnosis, up to 2.6 million in just a few years from now. Looking at some data that we have from the multi-ethnic study of atherosclerosis, this was a case-based study that excluded patients that had atrial fibrillation. So it was just looking at patients that were at risk for it. And it looked at about 6,000 patients that were being monitored for their first event of atrial fibrillation. And it calculated an age and sex-adjusted rate of hospitalizations due to atrial fibrillation. So if we look here at the table on the slide, we can see that over 1,000 patient years, the highest incidence was found in the white population, followed by that of Hispanics and Black patients. Further information comes to us out of a California database piece of information that we have, and this was a database that analyzed the breakdown of atrial fibrillation diagnoses and incidence based on age as well as race. So to take a look at this chart here on the slide, we can see on our y-axis we have the incidence of AFib, and on the x-axis we have both the gender of the patient, male versus female, as well as their age bracket category. So we can see moving from left to right that as a patient ages, we see an increased incidence in atrial fibrillation. In addition, we see, as similar to the last slide, that the highest incidence is in our white population, with similar rates of that of Hispanic, Asian, and Black patients. Moving on to prevalence, when we look at the general population, about 1 to 2% of our population has the diagnosis of atrial fibrillation. When broken down by lifetime risk, the chart here provides us with an overview of a comparison between white and Black patients, as well as males versus females. We can see the lifetime risk in both men and women that are considered white is between 30 and 36%. We do see that the lifetime risk is lower in our Black population. However, it is still over 20% in both men and women. There are a variety of risk factors that we can identify as healthcare providers, specifically as pharmacists, in our patients that put a patient at risk for the diagnosis of atrial fibrillation. I'd like to point out that a number of these risk factors are going to be crossovers from other cardiovascular disease states that we may treat in our practice. So we see comorbidities such as hypertension and diabetes, chronic kidney disease, and hypothyroidism that are very commonly diagnosed in the U.S. population. Additionally, there are lifestyle factors that play a role in AFib diagnosis, including obesity, smoking, and physical inactivity. Something that's becoming more and more of a concern over the last few years is alcohol consumption. We have found that moderate to high alcohol consumption can increase the risk of AFib diagnosis. as well as obstructive sleep apnea. So with obstructive sleep apnea again, being diagnosed more and more frequently, specifically here in the United States, we know that AFib risk rises as well. And finally, and very importantly, we must take into account the psychosocial factors that play a role in atrial fibrillation. So there are a variety of mental illnesses such as depression and PTSD, as well as lifestyle struggles such as stress and exhaustion that increase a patient's risk as well. And I'd like you to keep these risk factors in mind, because when we begin talking about screening here in just a few moments, they play a very important role in how we assess our patients. So why we care about atrial fibrillation, especially our undiagnosed atrial fibrillation, comes down to the complications that come along with this diagnosis and this disease state. The most common complication that we see with atrial fibrillation that's most well known is stroke. When looking at strokes across the board, about 15% of strokes that occur annually are attributed to atrial fibrillation. And the bigger issue here is that the strokes that occur due to AFib are found to have a greater disability and a higher level of or worsening morbidity in this population. On top of stroke, we can have systemic embolism, development of heart failure, as well as cognitive decline. So it's really important that we diagnose atrial fibrillation as quickly as possible in these patients and treat them accordingly so we can prevent these complications from occurring. Every disease state does come along with an economic burden, and that of nonvalvular atrial fibrillation is quite high. And we see that the cost is rising within the United States due to not only the treatment of this disease state, but also the very extensive complications. So we see costs rising due to hospitalizations and complications like heart failure and stroke. Additionally, with the treatments necessary, both procedural as well as medications. It's very challenging to estimate the economic burden of this disease state, but it's estimated that it's just over $6 billion per year that we spend here in the United States for the management and diagnosis of atrial fibrillation. We see that about just over half of that money goes towards hospitalizations in patients that have atrial fibrillation. And as pharmacists, it's really important to note that there's over $230 million spent each year on medications used to manage this disease state. Looking further into our economic burden, there was a study from 2015 that broke down a comparison of patients with atrial fibrillation versus those that did not have atrial fibrillation. And it compared the annual cost expenditure of healthcare. So we can see in patients between the ages of 18 and 64 years of age, there was a $10,000 increase in healthcare costs in patients with atrial fibrillation. Once patients were 65 years of age and older, that cost gap began to narrow a bit, but still was about $3,500 more annually in patients with atrial fibrillation. As I mentioned before, it's very hard to estimate the true cost burden of atrial fibrillation. We have a strong understanding that it is very much underestimated across the board. And really what's important is that we see that the estimated incremental cost burden specifically of our undiagnosed nonvalvular atrial fibrillation exceeds $3 billion. The concerns that we have for atrial fibrillation is although we've identified that it does occur more frequently in the white population and it is very costly, is that we do have healthcare disparities that we must keep in mind. Healthcare disparities are differences in care received by patients based on inequities or inequalities. We see this very commonly in our minority population and in our underfunded or non-funded populations. There are a variety of causes of healthcare disparities. One would be access to care and quality of care. In addition, if we have economic stability, so for patients that cannot consistently afford their treatments for atrial fibrillation, or even being able to see a physician or another provider to earn the diagnosis of atrial fibrillation, that can be problematic as well. We must keep in mind healthcare decision-making and those capabilities. Health literacy plays a very large role in patients' understanding of their disease states and of their treatments. And we know that the lower health literacy that patients have, the worse outcomes they tend to have as well. And then finally, especially in our minority populations, we must be respectful of the legacy of distrust. There's a historical perspective and a historical data showing us that our minority populations have been found to not only have less access to care, but also have much more poor quality of care. So it's not uncommon that this population may be distrusting of healthcare providers based on experiences they've had, family members, or other friends have had in the past. All of these disparities are extra concerning in that they prevent us from reaching our treatment goals and having the ideal outcomes in our patients with atrial fibrillation. This graph, it is a bit busy, so let's orient ourselves to this slide. So this is giving us an overview of access to care. On the left-hand side of the screen, we can see access to care broken down by race and ethnicity as well as income status. The first 4 bars on this chart tell us what is the comparison of a minority population as compared to the white population. So we can see our blue section of the bar tells us of these patients who is receiving worse access to care. So we can see a large number of our minorities, including our Black and Latinx populations, we see a lower ability to access care. This is even heightened more so if you look on the right-hand side of this chart, looking at in patients that are underfunded or non-funded, that they are more likely to have poor access to care. Moving to the right-hand side of the screen, this is broken down by disparities in access to care by race and ethnicity. And similar to the first chart, we see that our minority populations, including our Black and Hispanic populations, as well as our low-funded populations, are found to have either no improvement or worse access to care. Looking specifically at atrial fibrillation, I think it's important to identify the types of care patients should be receiving and what they actually are receiving to take those disparities in mind. Over the past 5 years or so, we've found that rhythm control strategies have additional benefits when managing atrial fibrillation. They have been found to improve quality of life as well as prevent some of our structural complications such as heart failure from developing. Antiarrhythmic drugs have been effective but have been found to be far surpassed by procedures like ablations, which do incur additional follow-up for patients as well as cost. Unfortunately, across the board, we're finding that rhythm control strategies, including ablations, are used much less frequently in our racial and ethnic minority populations and those in lower income brackets. Looking additionally at anticoagulation, which plays such an important role in the management of this population for stroke and systemic embolism prevention, we see that this registry data that's provided for you on the slide has been found to show us that anticoagulation is used less frequently in our Black population as compared to the white population. Now, they did further subgroup analyses that looked at a balance of this data based on adjustments for socioeconomic factors. And it found once we adjusted for socioeconomic factors, that difference in anticoagulation use was no longer an issue. However, I think this further points out those socioeconomic factors play such an important role in patients' access to care. So in patients that perhaps are of a minority group and are underfunded or poorly funded, we're very much setting these patients up for not being successful in obtaining and receiving appropriate anticoagulation. Specifically looking at our DOAC therapy, which are our treatments of choice for stroke prevention due to improved safety, efficacy, and lack of monitoring necessary or as much monitoring necessary, we see that the Black population is less likely to receive a DOAC therapy as compared to their white counterparts, regardless of socioeconomic factors. We found similar rates of DOAC use when comparing the white population to the Hispanic population. A bigger concern here is the quality of our anticoagulation use. When warfarin is used as our anticoagulant of choice in a patient, we've found that there's a lower time within therapeutic range in our Black and Hispanic populations, which means that they have an increased risk of either bleeding if their INRs are supratherapeutic or clotting if their INRs are subtherapeutic. And then very concerning, knowing that DOACs are our drug of choice here, is that we see much more commonly inappropriate doses that are being used in our Black and Latinx populations. So I'd like to take all of the information that we've discussed thus far and apply it to a patient case. So this is a patient that we're going to follow through the rest of this presentation. So I'd like to introduce you to Athena. She's a 63-year-old Black female presenting to an outpatient clinic for her annual primary care provider appointment. She has a past medical history significant for hypertension, type 2 diabetes, hypothyroidism, and obstructive sleep apnea. Looking at her social history, she does smoke 1 pack per day. She works as a receptionist, has a diet high in sodium and fat, and rarely exercises. She misses doses of her medications multiple times per week. And she does have insurance status. However, she has high premiums and high copays for her prescription medications. Looking at her vital signs, she is hypertensive. She is of normal body weight with a BMI of 23. And we did do the newest vital sign, which is a measurement of health literacy, and we found that she scored a 3, which shows us that she has a possibility of limited health literacy. Her laboratory values are unremarkable for the most part, except she does have an elevation in her A1C at 8% and elevated blood sugar. And she's on a variety of medications that you can see listed here on the screen to manage those comorbidities that she has. So looking at our atrial fibrillation incidence, we can see as a Black female, we can see she falls about a 5.8 out of 1,000 patient year chance of developing atrial fibrillation. So perhaps she's at lower risk than perhaps a white counterpart. However, we must keep in mind the variety of risk factors that she has that are increasing her risk of having this diagnosis and developing this disease state. Looking at her atrial fibrillation risk factors, we can see she has quite a few. They're listed for you here on the slide, including her hypertension, smoking and diabetes, lifestyle issues such as physical inactivity, obstructive sleep apnea, hypothyroidism. And the one thing that we have not gotten out of this patient yet, nothing that we haven't learned, is her psychosocial factors. So we would need to discuss things like stress and mental illness with this patient as well. So with that, I would like to turn it over to my colleague, Dr. Dwyer Kaluzna, to tell us about Module 2.
Thanks, Dr. Lusk. That was great. Hi, everybody. Thanks for joining. I'm excited to talk to you all about the various screening methods that we have at our disposal to help us identify and detect atrial fibrillation early, and how we can implement that as pharmacists in different practice settings. So the objective for this module is to be able to identify the various screening methods that we have for nonvalvular atrial fibrillation and their appropriate role in pharmacy settings. Now, there's several incentives for screening for atrial fibrillation. And when I talk about screening for atrial fibrillation, I mean people who haven't been diagnosed yet and trying to detect it as soon as possible to start treatment. As Dr. Lusk mentioned, we expect the incidence of atrial fibrillation to continue to increase over the coming years. And we also know that severe complications like stroke, hospitalizations, and mortality linked to atrial fibrillation are things that we can prevent if we detect it sooner and start treating it sooner. For example, for stroke presentation, about 10% of these patients who present with stroke ultimately come away with a diagnosis of atrial fibrillation. So that's 10% of strokes that we could potentially prevent just by detecting atrial fibrillation sooner. We also know that atrial fibrillation can be kind of sneaky. Patients don't always feel the symptoms related to this dysrhythmia. So utilizing other approaches aside from patient symptoms is going to be important in detecting this dysrhythmia. And we have an increased availability of various tools that I'm going to spend some time talking about to help us detect this atrial fibrillation and how we utilize them in our practice settings. So of course, with any sort of healthcare detection tool, that it's going to come with risks and benefits. The benefits to screening for atrial fibrillation probably seem pretty intuitive at this point. We can prevent some of the cardiac remodeling and hemodynamic derangements that we see with this dysrhythmia. We could potentially reduce complications such as stroke and other symptoms related to atrial fibrillation, as well as reduce potential hospitalizations and mortality. Of course, the risks with this could be the potential for overdiagnosis. The more you screen for something, the higher chance that you potentially overdiagnose, overtreat, and overuse some of our other invasive testing that come along with an AFib diagnosis. And then the anxiety that could come for the patient with abnormal results. Generally, the guidelines all sort of lean towards benefits outweighing the risks for screening for atrial fibrillation, and we'll talk about who is sort of indicated for screening. There's two approaches to screening for atrial fibrillation. There's an opportunistic approach and there's a systematic approach. So on this slide, we're going to talk about the opportunistic approach, which is kind of the general favorite approach, I would say, in the current guidelines. Basically, it's giving a patient who's coming to a pharmacy or a clinic for some other reason, you give them the opportunity to be screened for atrial fibrillation in that setting. This is going to be the most cost-effective approach compared to just the routine care that we're doing now, as well as the systematic approach that we'll talk on the next slide. This approach is recommended for any patient who is 65 years of age or greater, patients who are hypertensive regardless of their age, and patients who have obstructive sleep apnea regardless of their age. It's also recommended to detect for any atrial high rate events through devices. So if a patient has a permanent pacemaker or an ICD that can potentially detect any dysrhythmias, that you routinely interrogate those devices as an opportunistic approach to screening as well. So doing that in the clinic if you have the capability. Now, on the flip side, the systematic approach is taking a look at your entire system, utilizing your system to identify patients who are potentially at risk and then inviting them for a screening, a little bit different from an opportunistic approach, trying to be a little bit more proactive. This is more cost effective than the routine care, but it requires a little bit more legwork and a little bit more cost compared to the opportunistic approach. This is an approach that you can consider for patients who are 75 years of age or greater, or other patients who are at high risk of stroke. So patients with a prior stroke history, patients who have multiple risk factors for either atrial fibrillation or stroke. So those would be kind of the patients that you could think about doing a systematic approach. Of course, AFib isn't always just a constant present dysrhythmia. It can come and go. It can be present for very short periods of time. And so because of that, repeated screening is going to be way more beneficial than just a single assessment. So especially if you're going the opportunistic approach, making sure that you're providing those screenings at each clinic visit or at each time that you interact with the patient at the pharmacy. Before you do start, routinely screening the patients, it's very important to inform them of the significance, especially because one of the risk factors for this screening is patient anxiety, really giving them the full picture, the full scope of what an atrial fibrillation diagnosis could mean, starting them on blood thinners, stroke prevention, having that conversation with them from the beginning is going to be important. You also want to make sure that there's a structured referral platform. So once you do diagnose a patient with atrial fibrillation, how are you going to ensure that that patient gets the proper follow-up that they need? So making sure that that referral platform is in place as you sort of implement atrial fibrillation screening into your practice. In order to definitively diagnose a patient, it has to be formalized with an ECG reading. So this can be either a physician reviewing a single lead ECG for 30 seconds or a formal 12-lead ECG that demonstrates atrial fibrillation. So that's another sort of thing to have in place when it comes to implementing screening into practice. So revisiting our patient case, Athena, she's, as a refresher, a 63-year-old female with hypertension, diabetes, obstructive sleep apnea, and hypothyroidism who's here for her annual visit in her primary care clinic. You, the pharmacist, are consulted for blood pressure management, and you remember listening to this fabulous CE presentation, and you thought, does this patient meet the criteria for screening for atrial fibrillation? And I'll give you a couple seconds to just kind of think through yes or no and why. What is her potential indication? So hopefully you're all thinking, yes, this patient does meet criteria for opportunistic screening. Remember, she's in the clinic, so you want to give her the opportunity. She's hypertensive and she has obstructive sleep apnea, both of which carry recommendations for opportunistic screening. So you could give her the opportunity for screening today in the clinic, and then also make a note to try to continue to offer her those atrial fibrillation screenings at all of her follow-up visits. Because remember, repeated screening is going to be more beneficial than a single time point assessment at truly detecting atrial fibrillation. You could also offer her screening opportunities as she goes to pick up her prescriptions at her community pharmacy. I imagine she's hypertensive. There's going to be some tweaks to her meds probably at this primary care clinic visit. So when she goes to the pharmacy, that's another opportunity where she could potentially be screened for atrial fibrillation. Now, as I mentioned, we've got a bunch of different new sort of techniques and technologies that are available to us that help us detect atrial fibrillation. And I'm going to spend a little bit of time talking about the 4 that are listed on the slide here. The first is very simple, pulse palpation, just checking your pulse. Very simple, radial artery, right? It's very easy to implement, no additional cost. It can be done by a healthcare provider or patients with the proper training. Of course, if the patient does detect any sort of irregularity in their pulse, this does require an ECG follow-up for diagnosis confirmation. But the combination of pulse palpation plus an ECG for confirmation can increase the detection of atrial fibrillation by up to 60%. So this is a lot of patients that we can very easily help detect this dysrhythmia and start treatment as soon as possible to prevent some of those complications with atrial fibrillation. Another technique are handheld single lead ECG devices. These are actually really cool, and I'm excited to see kind of where this aspect of detection kind of goes over the coming years. It can be patient-initiated or provider-initiated. These are basically like little strips that you place your fingers on, and it links up to one of your smart devices, and it generates a very high-quality single-lead ECG. This is going to be more accurate than pulse palpation because it is an ECG, basically. And a lot of these devices have sort of these automated algorithms that allow them to detect for atrial fibrillation. So the 2 most common that were cited were looking for the absence of P waves and then an irregular RR interval, which are kind of the 2 classic ECG findings for atrial fibrillation. Some of these devices are also coupled with a cardiologist interpretation, so it gets sent off to the cardiologist for review to make that confirmatory diagnosis. So these devices, I think, are really fascinating, and I think will be really cool to see if we get an uptake of this in the coming years. When used repeatedly for 2 to 4 weeks, the diagnostic accuracy is basically equivalent to the event recorders that we're using now. And it's actually superior to a single 12-lead ECG or even a 24-hour Holter monitor for paroxysmal atrial fibrillation. So I think this is a great new tool that hopefully we'll see more and more use of in the coming years. Another great tool, I think something that we should really try to strive for most of our patients is oscillometric blood pressure cuffs. So it's basically an elevated blood pressure cuff that has the ability to detect for pulse irregularity. So especially for our patient like Athena, this would be a really great option since we're probably going to have her monitoring her blood pressure at home anyways. Why not add the capability of checking for pulse irregularity? These types of cuffs are very sensitive, very specific. They're also superior to the pulse palpation method, readily accessible for patient purchase. And then you can have multiple time points, right? It's kind of a repeated assessment since the patient's going to be checking their blood pressure multiple times throughout the day or week. Of course, this also does require that ECG for diagnosis confirmation, just like the pulse palpation method. And then the last method or piece of technology I guess I'll talk about is photoplethysmography. So this is another kind of really cool technology piece that you're all probably already somewhat familiar with. It's sort of incorporated into our smartphones and our smartwatches and other wearable devices. So, you have the one option where it can be sort of initiated on your phone, or it's kind of a semi-continuous monitoring of your pulse on your smartwatch or other wearable device. The other methods, it has sort of these algorithms that allow them to detect a dysrhythmia or identify any ectopic beats. And this is, I think, another really attractive technology just because of the widespread use of smart devices already. The one kind of caveat I will say is that it does require a noise-free trace to really have its best performance. So if you're wearing a watch and kind of like running around all day, moving your arms around, you might get some false positive interpretations just because it's not necessarily a noise-free trace. So that would be something to just kind of be cognizant of. And then it does also require a confirmatory ECG in order to make that formal diagnosis. So how do we as pharmacists, take this into practice, and why, I guess, are we the ones that should be kind of focusing on this? I think, we're all very proud to say that pharmacists are one of the most accessible healthcare professionals. We have so many patients that are coming to the community pharmacies on a daily basis who are 65 years of age or older with chronic conditions that predispose them to atrial fibrillation development. We see more and more pharmacists being incorporated into the primary care clinic. So I think pharmacists really have a lot of opportunity to help in the screening for atrial fibrillation. This could also help us identify other undiagnosed chronic conditions, right? We might identify, hypertension when we're looking for risk factors for screening, similarly for tobacco use, alcohol abuse, etc. Several prospective studies have demonstrated the feasibility of screening in community pharmacies using some of the various methods we've talked about, including pulse palpation, smartphone ECG, and then the oscillometric blood pressure cuffs. So how can we do this? As you're thinking about implementing this into your practice, it's important to think about which sort of approach style makes sense, whether opportunistic or systematic would be most feasible. In my mind, if our clinic group was going to do this, I think opportunistic would probably be the best approach. A couple of studies have cited using some advertising within community pharmacies to recruit patients for screening in primary care clinics, as I mentioned, and then a more systematic approach would be utilizing patient databases to identify those at high risk based on age, medications that they're picking up at the pharmacy, and then, of course, making sure, however it is that you approach the screening, that you're doing it multiple times, because, again, that repeated assessment is going to be more valuable than a single time frame. For pharmacist implementation specifically, the data seems to support utilizing devices with ECG or rhythm capabilities over things like pulse palpation just because of increased accuracy and sensitivity for detecting atrial fibrillation. Now, there's certainly barriers and concerns to think about when it comes to implementing this into practice. One of the biggest things that I've already sort of alluded to is making sure that referral system is in place. What are you going to do with the patient once you have that detection of an irregular heart rhythm? How are you going to ensure that the patient follows up, that they get seen with the electrophysiologist or cardiologist in order to get the care that they need? So that's something to make sure that is in place. I think the other concern, especially from a community pharmacy approach, is just the added responsibility to the already very hectic and busy day for community pharmacists. So just recognizing the time that would need to go into this sort of screening. Training is also something that would need to be implemented regardless of the method that's incorporated. Pulse palpation, making sure the devices are used appropriately, understanding the referral system, et cetera. And then patient privacy, of course, is going to be a concern too, especially in the community pharmacy setting where things are kind of a little bit more open than a private clinic room. So I'll conclude by just, mentioning, kind of recapping that screening for atrial fibrillation is going to allow us to reduce the burden of stroke and other symptoms by detecting it early and starting that anticoagulant as soon as possible to prevent that detrimental outcome. For patients who are 65 years of age or older or who have other risk factors, they would benefit from a screening, especially an opportunistic screening style. And we have several new technologies and devices that can make screening more accessible and simpler than before. And pharmacists, I think, are really in a unique position to implement this. And hopefully this, module helped give you some ideas of how you can potentially incorporate this into your practice.
Thank you very much, Dr. Lusk and Dr. Dwyer Kaluzna. And thank you to the listeners for joining us. As a reminder, to view the full program and to join the discussion, please click on the link in the show notes. As always, thank you for listening.